Welcome back, everyone. We're about to start the sessions for the remainder of the day. I hope most of you, at least for those who are here in person, enjoyed the demonstrations and another opportunity for Ask the Experts. Those of you online, well, we're sorry that you missed it, but we've got some wonderful talks coming up, and we're really excited for everyone to join again. I want to, first of all, point everyone's attention to the screen at the front of the room. Again, if you have any questions for the speakers or anyone else at the conference, in other words, those of us who are supporting the meeting, please send them to NIH Measures Conf, so NIH Measures CONF at mail.nih.gov, that's up on the screen, before 1 p.m. today. These questions will be, once we're through with the meeting, will be monitored and taken from the email box and will be answered after the conference, hopefully within days, maybe a couple of weeks. So we will get back to everyone who has a question or concern. All right. So to get started, it's my pleasure to again introduce Dr. Richard Gershon, Vice Chair of Research and Professor in the Department of Medical Social Sciences and Professor in Preventive Medicine at the Northwestern University Feinberg School of Medicine. For the talk he's about to give, he's had a wealth of experience. He's either the principal investigator of one of the principal investigators for the grant, contracts, or cooperative agreements for every measurement system featured at this conference. And for myself personally, I've had the opportunity to work with Richard for 18 years now, is what I counted, Richard, and he is a much valued colleague. So, Dr. Gershon.
Thank you. Thank you, Molly, so very much. So we're going to have lessons learned from developing and implementing measurement systems. This is first time I've had fun in a long time putting together a presentation. Usually I'm cobbling together slides from a bunch of other presentations. There is no old content here whatsoever. It gave me a little chance to reflect on things I've been telling people, and then I thought I would do this in terms of a top 10 list, but I could only get it down to 13, so you have to forgive me. And these are just my view of lessons learned across a large series of projects. You can agree, disagree. It's not meant to be that kind of list, really more of a list of things to think about. And number 13, for many of us who had all sorts of grants or things, a pandemic makes measurement more difficult, but maybe better. And the really changed the way we thought about developing measures. We were successfully able to develop, even validate measures remotely, which just would not have been in anyone's thought process, I think, prior to this period of time. And we literally had people on FaceTime, on Zoom, working with subjects, working with babies remotely with their moms to validate things. So it really allowed us to change processes. Integrating a measure in an EMR may take years, not weeks. Maria Varela reminds me of this all the time, and it's just true. We want to think that we have a great idea, and an electronic medical record group at our own institution is going to be able to load it up by Friday, and we're going to be able to use it. And even in our own institution, we've taken years. And by the way, once it's in, we're allowed to modify it in another year. So I urge people who are looking at those integrations, you may think you have the best relationship with that group. It's a different time frame than we're used to looking on. I mean, we have had some success working at the national level on things like that. The Patient Report Outcome Measurement Information System, it took us 6 years, but we have 500 measures there built into the core of an Epic installation. Getting these types of measures built in there automatically is somewhere over the horizon, although my COG effort is working very hard to do that and has done that successfully at Northwestern. Number 11, it costs a lot to develop a great digital assessment, and it is significantly more oftentimes than a paper-based assessment, but there are continuous costs to maintaining those. You know, and numerous people have asked me, is there a cost to do these things? Why is there a cost? And the reality is this: Apple, for instance, upgrades their operating system 8 times a year, and they come up with new hardware. And any of those upgrades could make a button no longer fit a piece of text, or could change a timer, or it could do things like that, which means we're literally, in order to have no change, we have to be working on an Apple-based system 8+ times a year. Add Android in there, and you're up to dozens and dozens of time of, we have some more quality assurance people here doing that. So it's not a one-time event. We can't make it up. It's not like a thing in your file cabinet you can pull out and re-Xerox it. Number 10, investigators and clinicians want support. I would love to say we create a measure and we're done, we put it out there. No, they want pre-award support. They want to understand how to load it. They want to understand how to interpret the data. They may not want to hear it, but they interpreted the data wrong. And they want somebody to reach out to. And in our case, I mean, it means we have at least one full-time resource and then a lot of part-time people around doing that at all times. And because it's what you, if you're a researcher, need and clinicians need. We don't provide real-time support. Very often you can get it, but people want it, need it. It's a service that has to be available if we want a measurement system to be used. Oh, one of my favorites. Investigators believe that measures developed with NIH funding should be free. I'm sure this will come up later in in our little panel discussion. All the measurement systems that I've been involved with, I believe, had something on there, and that is, make certain that you've covered, future sustainability in your development plans. So that flies directly in the face of the fact that there are going to be 8 upgrades a year from Apple. So generally speaking, that's the way the NIH views things, and that's fine. It just means, however, that when we get those questions, we have to figure out a way to do it. I can't help myself. I'll give my Tempur-Pedic bed example. Tempur-Pedic, that material was developed by NASA in order to cushion these seats on the space shuttle, and I'd like my Tempur-Pedic bed for free also, but it's not going to happen. And in the same way, since there are continuing expenses on digital assessments, somewhere it has to be paid for. My favorite nightmare, or not favorite. Never lose a piece of digital data. A paper test can always be re-entered. We have to remember the lessons we had on paper, and that is until your data was fully loaded, fully QA'd, you never got rid of that paper copy of the form, and many of us still have paper forms from 20 years ago sitting in a file cabinet just in case. Digital doesn't afford you the opportunity to keep a copy in the file cabinet. And you really, on your own, I'll switch it down to the study level. Your job is not over until you have confirmed and reconfirmed, sometimes daily, no more than I would say weekly, that the participant who came in to take a test on Monday morning, that the data is in your analysis data set, that it made it all the way, that it got off of the iPad and was uploaded to a central data repository, that it went from there to wherever it's supposed to go, that it was QA'd along the way. Because if you start missing for any sorts of reasons, you may not be able to get it back. The paper is gone. So test it. I mean, we actually have 2 full-time commercial level QA people. At least one of them is here today. And we do that because we're QAing on a commercial level, not on an academic level. But you have to check it out yourself. When all is said and done, it's the investigator, the clinician, is the data there. And if you're a clinician, download the data, print your report so you have a copy. You know what I'm saying? Our devices, our iPad, Apple devices are set up correctly, do local backup. But if someone steals that iPad, was that the only copy of the data you had? It's just an easy thing to forget. Number 7. By the way, any of these topics I could speak for an hour on, so I'm just kind of powering through here. Know all the players, not just the test taker. It's really easy to get an assignment to pick a measure or to create a measure and say, this is the purpose I was given. But the reality is a measure is who gives it, who schedules it, who hands, in the MyCog instance, who's going to hand the person the iPad, who's going to get the iPad back, and studies as well. So you need to know all the players. Who's the clinician? Now, many people go to in a research setting, you go to the doctor in the clinic because they know everything. They know a lot of things, but they probably have absolutely no idea what's really going on prior to the patient getting to their room. And the majority of the interaction with the iPad may be before then. So you need to talk to the people who are rarely at the table. It's the clerk at the front door. And by the way, it's also the patient who doesn't understand the instructions you gave, but it's really noticing or talking to everybody along that way. So a lot of the work we do is qualitative, and when we use these measures, we've tried to create the measures so they can easily integrate into different environments, but that's where our job stops with creating them. It's your job when you're setting it up. Does the entire workflow, and it's not assigning it to a research project manager who's going to figure that out. You've got to take responsibility for every step along the way. And the measure may not be appropriate because of the people in the process. It actually might be fine for the participant. But if that, if the IT person who's responsible for data flow into the electronic medical record says, I can't move that data from this measure, that may ultimately be the reason you can't use that measure. Having nothing to do with it's the most reliable, valid measure you can get there. 6 diversity matters, and I mean a lot of definitions of the word diversity. There are tests where asking the same question to 2 different groups, and it could be gender, race, ethnicity, age, gets a different answer, and they're correct for one group and incorrect for another group. My favorite item I like doing this was when patient-reported outcomes measurement information system was developing a depression scale, and there was an item on there. I have tears in my eyes once a week, more than once a week, et cetera. And it turns out that that item is a predictor of depression, but not for women, and not for me, because I happen to get tears in my eyes at sappy movies. I'm sorry I have to admit that. But no, so it turns out that people who are emotionally affected by watching movies very often have tears in their eyes. It turns out men, for whatever reason, are less likely to do so. So if most males, if they cry once a week, it's likely a predictor of depression, and most women, if they cry once a week, it is not. That doesn't mean that there aren't people from both genders going both ways that do that, but you have to look at the underlying content. Is it there? So Promise pulled that item. Actually, Promise is unique. They got rid of as much diversity out of their content as possible. Not that you can't adjust for it, but the other point is this: our measures rarely have enough data to do the adjustments we'd like to do. It's the argument in the neuropsych community about race-adjusted norms, which half the neuropsych community very much wants them in there, and they have logic there. And the other part is, if you look at it, very often those norms were created by 100 people from a given subgroup out of thousands, and we're doing predictions based across ages. You can't get there. The other thing is, in terms of creating measures, in a perfect world, we would create measures de novo for each subgroup. The problem is today, people are members of multiple subgroups and they interact. So I think you have to develop in an economical way. Tests aren't bad. It's how they're interpreted very often. I'm sorry, I apologize. Some tests are bad. But generally speaking, are you aware of where diversity could impact those test scores? Are you aware of them affecting people differentially that's bad for them? And the flip side is, I had heard a very cogent argument, which I didn't agree with, that we shouldn't give performance measures to kids in environmental child health outcomes because it's a diversity issue. And I'm thinking, yes, they've been misused much more so in the early 1900s, but it happened. And the flip side is, we don't measure performance outcomes on kids, then there is no impact of environment, which is what ECHO's setting out to do, right? We won't catch the fact that people who live in an area with high pollution have lower executive functioning scores, because if we didn't measure that outcome variable, we're not going to catch it. We just have to make certain we're interpreting versus the correct diversity. And obviously, a lot more to be said there. Tests that cause missing data are a big problem. These are overlapping issues. If you're testing people where the impact of a drug or the impact of an exposure causes blindness, but you have no tests for blind people, therefore blind people are missing data, therefore those exposures didn't cause blindness because they're not even in your study. You have to be very, very careful. We all do lots of national things and they're represented, but I'm going to guess the average person in the room is from an academic medical center based in a relatively high SES area, you are not representative. I'm not representative of the United States, of the world. Have to make certain to incorporate those small groups, because if we don't incorporate them, they're missing, and missing this could kill the results of what you're doing, or completely miss out on finding the impact that's really important. Oh, this one we learned the hard way with the original NIH Toolbox. People often want to be tested in the language they read, not the language they speak. Popular census logic is you want to know language spoken in the home. Well, with the original norming of the NIH Toolbox, which was in a different era to some degree relative to diversity and certainly relative to federal guidelines required to change your selection criteria of who's in your sample, we brought people in who indicated they spoke Spanish in the home. They got to the testing site and said, I can't read this content, because people who speak a language in their home may not know how to read it. I think the better question may be is, what language do you read your comic books in? Or literally, what language do you read? Because if your test has any written content, there's a large component of the population, certainly by the time they're through first grade, they don't write that language. And we are not, I think people who develop measures and interpret measures, we're not in a good position to interpret people in a separate language, and let alone bilingualism. And people always ask me, what are you doing for people who are bilingual? Bilingualism is an interaction effect, and in order to really draw conclusions about people who are bilingual, we're going to need to test hundreds and thousands, not the 25 that are going to be in a 2,500-person norming study, because that's the percentage, but that's not enough. And the flip side is, we know bilingualism appears to have a positive impact for making certain people are less likely to get dementia. So, actually, bilingualism is really important, and yet we don't have the tools to assess it. So, again, the reading versus speak. If you're doing your first study in a foreign language, I urge you to check out the subpopulation you're dealing with. My guess is that will prove true. 3, some measures can be translated, others cannot. A fluid intelligence measure, measuring executive function with very little language, you're just measuring translating the instructions, likely can be translated, will be very applicable in other languages. However, I think as I mentioned yesterday, that doesn't mean the content. To me, translation and cultural translation almost go hand in hand. It depends where you're at. But again, my blueberry example, another favorite example is I am able to pass, this is not a toolbox measure, but I can easily pass a turkey around the table. It's a physical functioning item. Well, in the United States, passing a turkey is you can pass something that's 15 to 21 pounds, right? In Europe, passing a turkey is the same size as a chicken. And so there's it's a cultural issue. And it's something I never would have thought of, but it's an item that ended up with differential item functioning across cultures. So language measures, we know when we developed, we know the importance of reading as a predictor and as a developmental variable it's in the regular NIH Toolbox. But when we got down to Spanish, turns out that any first grader, so I'm told, can correctly pronounce any word in Spanish by the end of first grade. So there's an example. We can translate the measure, but the meaning is different. And how we're going to use the meaning varies by language. So you have to be very careful. You really need people who are not language experts in English, but who are language experts in the language that you're working in. Number 2, it's important to understand how a test score will be used prior to developing or picking a test. It's really easy to find the most popular test, and bad news, many of the popular tests used in clinical settings, which is why they're not in the original NIH Toolbox, were validated for use in kidney patients and are now used across diseases, and nobody validated them in the other diseases. But how's that test score going to be used? If you're using a test to differentiate people who are on a drug and versus not, you can use a relatively unreliable measure because the average survival time of these 500 people is hopefully better than those 500 people. I don't need clinical level reliability on each person. I can therefore use a different type of measure. If I'm going to be I don't like disparaging the National Children's Study, but one thing it certainly got wrong, among others, was they set separate teams out to determine what measures should be for kids in neuropsych. And those teams in aggregate said a 3-year-old should be tested for a total of 30 hours because that's what we needed. Anyone who's had a 3-year-old, knows a 3-year-old, knows you're never testing a 3-year-old. They won't be 3 by the time you're done, that's for sure. So you have to know the audience you're dealing with, how much time is there, and then how's that score going to be used afterwards, because we don't need that level of reliability. We don't need clinical reliability in every test we do. And I'm happy to report most of the Toolbox measures set out to be at much more of a broad level. Many of them have clinical level reliability. It wasn't the goal, but we did it anyway. And number 1, the impact of burden. It's a weird thing to say this is the most important thing in developing a test or picking a test, but I really believe it is. And it's not on the list of things that I learned in my clinical psych classes. It's not in the NCME-AERA guidelines for how you pick a test. But when all is said and done, you have to understand the burden of your subject. So the previous example I gave of 3-year-olds, 3-year-olds are never going to be tested for tens of hours. In a clinic setting, if you have to test a person before they go in to see their clinician, you have minutes. You don't have 45 minutes. And the other thing is this, people, and it's worse post-COVID, people aren't going to give you 5 hours or 4 hours. Every once in a while they will, and if you're doing a research study related to their disease, you'll get them for longer. But you have people in a longitudinal study and you keep them 6 hours the first time, guess what the likelihood is of them coming back the second time? Really low. So you have to do burden first. By the way, particularly if you're picking measurement batteries, so I'll go to the NIH Toolbox. We surveyed hundreds of researchers, said how long could this be at the most, and we arrived at 2 hours and half an hour. Bob Heaton's not here, but I've repeated this anecdote with his permission in the past. He said, Richard, it is never happening. We are never assessing cognition in 30 minutes. You are crazy. I like you. We're going to do it. We'll be on the committee. Or crazy. And 5 years later, he said, you did it. And the did it is because it was necessity. If we had a battery that was 45 minutes an hour, nobody was going to include it next to their other variables. So burden is it. And my red light's saying so relative to my burden is finished. And I think we'll move on to our next session. Happy to talk about these outside of here. Thank you. Jenni here. Oh, you scared? Go.
Hi, everyone. I'm Jenni Pacheco. I'm a scientific program officer with the Research Domain Criteria, or the RDoC unit at the National Institute of Mental Health. For years, the RDoC unit has been particularly interested in supporting the use and the development of common data elements that can be used across many different research projects. The NIH Toolbox, Baby Toolbox, Mobile Toolbox, and MyCog are all wonderful resources to help promote the use of consistent tasks so that we can be sure that we're all using the same measures and talking about the same constructs across multiple data sets and studies. I'm thrilled to be able to be here to moderate this session and dig into some of the most commonly asked questions about these measurement systems. Prior to this meeting, a request for information went out to the public, and we've pulled some of the most frequent and important questions to ask here during this session. We won't be answering any additional questions from the audience, so if you have questions as we go along or even after we've ended, I'd like to draw your attention to the email address at the bottom of this slide. You can submit your email questions to nihmeasuresconf@mail.nih.gov, and we'll get to a response out to you in the next couple of days or up to a couple of weeks. So without further ado, I'd like to introduce our panel and get started today. We have Dr. Richard Gershon from Northwestern University, Dr. Bruno Giordani from University of Michigan, Dr. Jonathan King from the National Institute of Aging, Dr. Julie Hook from Northwestern University, and Dr. Erica LaForte from Northwestern University. So I'll get started with our first question. I think this one's going to be first for Richard, and then John, if you want to add anything, you can. The NIH is funded with taxpayer dollars. Why are they charging $600 a year? If the NIH paid for it, shouldn't the NIH Toolbox be free?
I'm green. There we go. Maybe the red was my answer. Okay, I mentioned a little bit just a few minutes ago. It's a matter of we want to keep the tools available, and that requires having full-time people checking these things. And the other thing is, for instance, most neuropsych measures get renormed every 10 years, and we actually just did that without direct NIH funding by aggregating our license fees over time, and with some participating grants that were for the NIH Toolbox. So no one's making money on these things. We're actually run by the holding of the copyrights by a nonprofit. All the board members of the nonprofit have agreed not to take any remuneration for that. We're just putting it together to make certain those measures are available. We believe we're at a price point that makes it reasonable to use, and we hope that everybody agrees. And I wish they were free too, trust me, but we just haven't figured out a model, and if someone knows somebody with deep pockets that'll pay the annual cost, we'll take them and make it free.
Yeah, and just to add very briefly to this, what's really surprising about a project like NIH Toolbox in particular is that it can have an indefinite lifespan. And when you're making decisions about the use of NIH resources, you ask a bunch of institute directors or director of NIH, there's always a concern about an infinite lifespan potential. And so the idea is that we thought that clearly the resource was well worth developing in the first place. And the feeling has generally been at NIH that those things that prove to have continued and sustained value will show that value by people continuing to use them. In many cases, of course, writing grants or responding to cooperative agreements or contracts with NIH, which will then use the resource and will actually be paying for the resource then as well. It seems sometimes a little bit like one-handed juggling, but in most cases, it does seem to work out that you can sustain an activity that's going to be sustained through the kind of contributions that can be made to keep the resource going. And again, there are other alternatives. Actually, if you look at the Bayh-Dole Act, you can actually anything developed under the U.S. government can actually be used for a private gain pretty much forever. With some asterisks, you can ask me later. But by and large, we're very happy to see that the Toolbox development effort, which started even before I became involved in 2007, is still going on. So clearly, we've been able to sustain this for a greater period of time than other projects I won't name.
Thank you. That's great. I actually hadn't. It was really helpful for me to know how often they have to get updated just for iOS or hardware changes. I was clueless. Our next question has a little bit to do with this kind of idea of continuity. I think it's going to be for Erica. If I'm collecting data on my study using version 2 of the NIH Toolbox, what guidance or support do you have for studies that will be ongoing past the end of the life of the version 2 app? And how can longitudinal cohorts harmonize data between version 2 and version 3, given the changes between versions?
Yeah, I know this question is on a lot of people's minds as they're thinking about upgrading or transitioning to the new NIH Toolbox version 3. And I guess I wish that there was a real straight answer for that question. Unfortunately, it depends. It really depends on your study, how you're using the scores, what test scores and composite scores you might be using in your study. And so I think the first thing I would recommend for users is that they look at the second chapter of the technical manual, which is now posted on the NIH Toolbox website. We have a lot of great information in that chapter about measure by measure what's changed. And sometimes it's the practice items have changed. Sometimes the live items have changed. So just kind of assessing which tests that you're using and getting a real good feel for how the new tests are going to be different and what kind of impact that might have. Some of the tests are very similar at certain ages and maybe a little different at others. So looking at the ages of the examinees or the participants in your research is also going to be useful. And then I think the other thing that's going to be helpful to look at in that technical manual is a study that we did during the norming where we looked at version 2 and version 3. We gave the same group of people both versions, and we report the results of that study in the manual as well. So we report correlations, and so you can get a little feel for how closely these scores correlate between the two versions.
Great, thank you. There's a lot of work that goes into maintaining the two versions. Julie, what if I need urgent technical assistance while administering the measures?
Thank you, and thank you all for having me. So I think the question is, what do you do if you have an urgent technical question? How do you get it answered? We offer online, 24-hourly available FAQs on our website. You could search them with your question. You can also use our chat bot and have your questions answered there. During normal working business hours, which for us are 9 to 5 Central Time, Monday through Friday, if you use our email for the help desk, that's monitored by our customer service lead, and she typically gets answers to folks within about an hour or so. If you have a very urgent topic, you can always write urgent in the subject header, and we will try and respond to you as quickly as possible. If it's outside of those hours, we do try and get back to you within the next business day or so. We also we don't have a call line, but if you email us and want to set up a time to talk, we're more than happy to do that. And lastly, we really encourage practice. So if you get the Toolbox app, we ask that you practice ahead of time, and then you could ask us any questions that you have in enough time that hopefully you could work out some of those kinks in advance. Thank you.
Great, thank you. Bruno, could you provide us an example of administering these measures outside of the United States or as part of an international consortia?
Sure. There are a couple of ways you can do that, and a couple of ways that have been done and been published. One is the very elegant work that comes out of Kenya from Duffy and company that really adapted the entire toolbox and very carefully did that, including was a long process. It was a grant-funded process, and did some alterations of items, adaptation of words and things. That's a very good process. It's just long and can be expensive and time-consuming. Another way to do it is to really do a scripted translation of the instructions. You have to work with Toolbox, get permission to do that. They provide a tremendous amount of help in doing that as well. And then you can work through that scripted interpretations in the environment. We've done that in Uganda. It's been done in Zambia as well successfully. And it's very, very effective.
Great, thank you. Our next one is a two-part question. So I'm going to start with the first part, which I think will be for Erica. What if I want access to the measures or code to modify it for my particular needs or cases?
That's a good question. And generally, we don't recommend making changes to the standardized measures simply because the measures have been standardized and normed in their current form. So anytime you would think about changing instructions or changing items or changing the way that an examinee participates or interacts with the test, you're necessarily changing that standardized procedure. And so it may invalidate or reduce the utility of the scores that we've gathered through our norming study.
Great. And John, the next part of that is, what if I want to add a custom measure to my battery? Can I do that?
Well, that's actually a very different question. So a battery of multiple tests, obviously many people use NIH Toolbox with a wide variety of other tests, and that makes perfect sense, of course, because in many cases there are constructs you would like to measure that aren't in Toolbox. There are any number of other sort of covariates or things that you would need to know. It makes perfect sense. And I'd like to point out that that's actually going to be facilitated fairly greatly for mobile Toolbox because it's actually embedded within the REDCap system. And if you are familiar with the REDCap system, you're aware that many questionnaire, I think some actually also behavioral measures have been adopted to use within REDCap. And so being able to use NIH Toolbox measures with others side by side and seamlessly is a great thing. And I think would also tend to temper enthusiasm for, again, messing with the one measures we actually have the validation for outside of your own validation.
Richard, do you have anything to add?
Yeah, there are opportunities. Most of the tests that we're dealing with come from accepted paradigms, and I urge people, and if you can't figure out what paradigm, we can probably help you find it and to develop it elsewhere. What we don't do is provide the underlying code, although many of them we've published over time. We've just found when people are doing direct derivatives of what we have, they need lots and lots of our time. We just don't have it. It's not there, which is why we direct people to other places. But we do, under grants and with other people, the latest release of the NIH Toolbox has 2 or 3 new measures, many updated measures, and they were done in conjunction with some of you in the room and to develop those. And so several people have come up to me today and said they have a validated measure. We'll look at them. I can tell you there will be no major new release of the NIH Toolbox until 2032, 2033, because people don't want the underlying measures to change longitudinally. So on the other hand, I agree with John a lot. The red cap, my cap environment allows you to hand key in new measures and do things in real time. And so there are additional opportunities to do that there.
Great. Back to another question about the costs. And for Julie, are there any discounts or resources for students who may wish to use the NIH Toolbox but can't afford the full price, analogous to a student discount available for some other testing systems?
Sure. The NIH Toolbox and our team that works on it really want to make all the tools and systems we work on as accessible as we can to all qualified and interested users. We do offer online resources completely for free. The administration manuals, other support materials, training materials are all available for free. The charge of the app, I think, has been addressed by Dr. Gershon a couple times. We do look to cover our operating costs and other costs that come from maintaining those measures, but it could be restrictive for some. If you do have an issue, we invite you to email our help desk, and we're happy to review that on a case-by-case basis to support use of the measurement system.
Great, thank you. Richard, when will the translation to Spanish be available for version 3? And what are my options if I need a translated version of the NIH Toolbox for my study?
Pretty sure I can report that V3 is available and is in the App Store. So this question came in before that was true, so it's not that they missed it. V3 is out there in Spanish, so that happened. If you're interested in other translations, we have a team that's continuously working on translations. Bruno discussed some ways to do it, and the least expensive way is to turn the volume off and to do live. That'll get you to the table the fastest. If you have the type of funding that can support upgrading the modification 8 times a year for the next X years, and we can get that cost pretty low. We're happy to work with you with the need, and it really depends on the level of translation. If the need is for the fluid tests, that can be done in months. Months is probably 3 to 9, not next month. If you want to literally recalibrate or develop a vocabulary test, something like that, that could take a couple of years. And we have some pharmaceutical companies right now that want to do that and renorm them prior to using them. That's going to cost literally hundreds of thousands of dollars. It will take 2 or 3 years. We don't pocket any of that. It's going to data collection efforts and analysis efforts. Those are all possibilities. I said briefly in this slide what we have now. So English, Spanish, Fertile Crescent, Arabic, Hebrew, French, I think are right now in V3, or no, not French. Oh, well, I should ask Julia. You're asking the wrong person this question. So. But we're in a lot of languages. We are exploring another 6 languages with pharmaceutical companies right now. And when we do that, we will try to make them available to everyone. And we're actually looking in the future to try to make foreign language versions available in native countries because, frankly, the amount that a researcher needs another language in is relatively minor to the potential use around the world.
Great. Julie, did you want to jump in and say anything?
French and Italian are being developed, and they'll be released later this year.
Perfect. Thank you. All right. Erica, how are these measurements built?
Well, that's a really big question. Let me see here.
in 3 minutes.
Yeah, okay, in 3 minutes or less. I think I want to probably highlight here one of the defining features of the toolbox, and especially in the version 3 measures, where we made a special effort to calibrate and scale all of the tests onto a score, a common metric called the change sensitive score. And as the name implies, it's a metric that's sensitive to change. And so I've talked to some people here at this conference who have been interested in looking at tracking growth or change over time. And so I just want to highlight that the change sensitive score metric is an ideal metric for that, because it, unlike a standard score or a norm reference score, where you might know about the person's standing, relative standing in their peer group, a change-sensitive score will actually tell you if that person has grown or changed or declined in some cases. And so that underlying metric is used for all of the tests in the third edition. It's also the metric that enables us to do things like computer adaptive testing, because we put people and items on the same scale, that same underlying scale. We're able to administer for tests like picture vocabulary and oral reading recall. We're able to administer fewer items because we can zero in and target that person's ability relative to the items that we've given them. Based on how they've answered those items, we can tell if they need an easier or more difficult item. And that helps us to keep the test time down and to really increase the precision of those tests. So, yeah.
Perfect. I tried to explain that to some of my kids who were taking the SAT this year for the first time on the computer. Julie, my IT office won't let me use the App Store. How can I get the NIH Toolbox on a mobile device management system?
So mobile device management, or MDM, was a term that I learned when I joined the Northwestern team. It's a different way to deploy an app, and a mobile device manager is really a software that lets you deploy 1,000 apps to, say, a high school class, or somehow control what the iPad is doing. So if you didn't want that end user to be able to download apps or to export certain things, that mobile device management software would help you control that and help you, again, to deploy to large numbers of devices. Our App Store version that's currently available for download unfortunately can't be deployed via an MDM because it requires an in-app purchase. So we're really working on getting an MDM-compatible version, and we hope to have that out later this year, hopefully by this summer. But please email the help desk, and we're happy to keep you up to date as we have updates. Thank you.
Great, thank you. One more for you, Julie. Won't I need thousands of dollars in hardware for things like iPads or accessories and external equipment just to start using these tools?
I think Erica used the term "it depends" a little earlier. And again, it depends. If you own an iPad and you want to use the emotional health tests in the NIH Toolbox, then really the cost is that of the app. But you should look at what hardware you have available and what equipment you might need for what tests you want to use, and then what system you're using. So, for example, if you need to buy an iPad for the NIH Toolbox, you could go with a $300 or $400 version, and then it would be the cost of the app itself, and then any other outside equipment that you might need. For example, the motor tests, some of them require a 9-hole pegboard or a grip strength, so those costs should be factored in too, but those are one-time upstart costs. And then lastly, the baby toolbox does require a more expensive iPad because it uses a more sophisticated camera. So if you don't own that type of iPad, that would be a higher initial cost for that, and then the yearly use of the app.
Great. All right, and we're on to our final question. And I know there's a couple of you that have answers for this, but the last question is, when will Mobile Toolbox, NIH Baby Toolbox, MyCog be available, and what will I need for the new assessments, and how much will they cost? John, if you want to get us started for Mobile Toolbox?
Yes, Mobile Toolbox. Drum roll, please. Will be released in May, that's next month, to a REDCap server near you, as long as you update the REDCap server to include it. Not every site will have the same update dates for their servers, but you can obviously pester your people to do that. And the other great thing about that is because it's currently still being developed and under a cooperative agreement, the cost of for the mobile toolbox, while we're supporting the development directly in the cooperative agreement, is zero. So the costs are being recovered by the cooperative agreement used to develop them. So, zero sounds good. So I think that people should all download it and find out what it can do and what it can't do, and let us know what it can't.
Great, thank you. And Julie, for NIH Baby Toolbox and MyCog.
So we're excited the Baby Toolbox will be coming out before the end of the year, and that will be priced at the same price point as the NIH Toolbox app is in the App Store today. So it would be $600 for up to 2 iPads. And MyCog is still being worked on in a research capacity. We don't have a set cost or time frame yet for release, but we certainly welcome people to reach out to us for collaboration or just updates on what the release date might be in the future. Thank you.
Great, thank you. I just want to have a chance to thank all of our panelists for making my job easy and staying completely on time. And for anyone that still has questions that maybe we didn't get to or that came up after hearing this, the email address is up at the bottom of that slide that you can send some emails to and ask your questions. So thank you guys, and enjoy the rest of the day.
Thank you.
Thank you.
All right. Well, we continue to have some exciting programming, so I hope everyone stays seated. Our next speaker is Dr. Jennifer Manley, Professor of Neuropsychology and Neurology at Columbia University. Dr. Manley's research focuses on cultural, medical, and genetic predictors of cognitive aging and Alzheimer's disease among Blacks and Hispanics. She's worked to improve the diagnostic accuracy of neuropsychological tests for detection of cognitive impairment and Alzheimer's disease among minoritized groups, really helping to clarify some of the influences of things such as language, acculturation, educational experiences, racial socialization, and socioeconomic status on cognitive test performance. Dr. Manley was part of the team for the development of the NIH Toolbox and was instrumental in the validation study of the NIH Toolbox measures in individuals with mild cognitive impairment and early-stage Alzheimer's disease. My professional interaction with Dr. Manley dates back 26 years by my count. She is a much-valued colleague. And for the presentation she's about to make, she's the very first person who came to my mind who could really bring us to a thoughtful way forward for a framework for equitable assessment and development of fairer measures. Dr. Manley.
Thank you, Molly. No worries aging us, both of us. 26 years, you said? That's a long time. Thank you so much. I want to provide some thoughts about approaches to equitable cognitive assessment. And just full disclosure, as you know from my introduction, I'm a neuropsychologist. And what did I do? Thanks. Thank you. I'm a neuropsychologist, and so this talk is going to be focused on cognitive assessment and not so much assessment of motor or emotional functioning. And my research focuses on adults and older adults, not babies. But I do think that some of what I'm going to talk about applies to these other life stages and other domains of assessment. And after spending all of yesterday with all of you, I know for sure that I'm certainly not the only expert in the room. You all have deep knowledge and expertise in adapting the toolbox to different communities and different environments. And so there's clearly a wealth of knowledge that can be harnessed for next steps in this area. So as we develop a framework to guide fair and cognitive measures, it should center health equity. And I believe there's some core pillars to centering health equity in research that apply especially to cognitive assessment. So when developing and validating assessment measures, inclusion should be the highest priority. And there's a science of inclusion. There are scientific experts in inclusive research as well. It's a whole sub-discipline in and of itself. And there are frameworks and conceptual models like the one on the right that was developed for the NYU Center for the Study of Asian American Health. There are journals, manuscripts, courses, and workshops that delve into the science of inclusion. From conceptualization of a study to clarifying goals, attaining resources to support inclusive practices, to the gradual and resource-intensive process of building trust in communities, listening and acting to remove barriers to participation, there are best practices and a literature to support the science of inclusion in brain health research. And when we look at successful research studies in health equity, those research studies adhere to these best practices. So before measures are developed, communities need to be involved and engaged in defining or informing the research question or the purpose of the assessment. And for neuropsychological research, having a community advisory board or an expert panel on cultural issues and assessment isn't usually sufficient to cross that bar. So I recommend right now the writings of Gina Green-Harris and Raina Croft, who are both involved in recruitment in the science of inclusion in brain health studies that have been very successful. And they describe their community-engaged approaches. And the key step here is to define your population, to define your study population. You need to know who you're going for. And then a literature review should be supplemented by a historical review of the people and the places where the research will be conducted. Another pillar is commitment to fair assessment. And again, the intention, just the intention to do good, is not sufficient. There are principles of fair and unbiased assessment, and their core is based in social justice. For brain health, what this means is awareness of and focus on changing the fundamental systems of inequity that led to disparities in brain health. And a lot of specialized tools are needed for this. This commitment must include expertise in advanced psychometric techniques that can be used in the development and evaluation of the measures. And of course, commitment to workforce diversity, and we'll talk about that more later. So I've listed here some dimensions for diversity that we need to consider when developing and validating cognitive measures. These are a few, and I think they're very important for cognitive function. And I also think that neuropsychological research is behind the times on sort of lagging behind scientific best practices with respect to characterizing identities of our participants and our patients. Our reliance on convenient samples means that we have not explored the full breadth of these dimensions. So, for example, I've had several trainees that are interested in sex and gender effects on cognitive test performance. So they go back to existing data sets and ask the question, first, how were sex and gender collected for this study? And it's ugly. It's not pretty. because it's scary to find out the number of studies where sex and gender were assumed by the investigators based on appearance, name, or even how their voice sounded over the phone. When asked, gender or sex options often remain limited to binary choices. The optimal approaches for collecting this information ask about sex assigned at birth, sexual orientation, and gender identity. And when it comes to study design, data collection, and data analysis, serious oversight occurs concerning transgender and gender diverse individuals. These communities are often erased by the simple process of our data collection procedures. Small sample sizes are no excuse for overlooking these individuals. Not only that, transgender people may feel reluctant to participate because we did not design these questions inclusively. But also, intersectionality matters. This term, intersectionality, refers to the interconnections between or across social categorizations, such as race, socioeconomic status, and gender, as they apply both to a group and also an individual. So these overlapping systems of disadvantage or discrimination create unique experiences that are not additive, they're interactive and interdependent. So it's not only these individual dimensions that we need to account for, it's also the intersectional identities that are represented in each population. So let's talk about some issues to consider for development of fair measures. I think first we need to seek collaborators from historically excluded groups. Do not include them only for superficial consultation, but they must be equal partners in all phases of the study. And this might mean changing the leadership of your study in order to fully realize that partnership. We need to, for each project, define fair and unbiased. We all know the APA definition of fairness, which is comparable validity across groups within the population of interest, and that fair testing strives to diminish or avoid factors that may produce bias. Research teams should clarify their goals and set expectations for precision in the early stages of development, because sometimes the process of harmonizing or finding factors that are common across groups or adapting items creates a less precise instrument for all. Collaborative review of potential content should happen very early in the process. And collaborative, I mean not just researchers, I mean researchers and community members. Yesterday during her presentation, I heard Amy Thomas say that some older adults in the Strong Heart study thought it was strange that the Toolbox test did not offer accommodations if they were needed. All of us have tested individuals with hearing impairment, limited vision, limited mobility, or in different assessment settings. So, we've tested people not in their house, but in their yard, outside, where lots of things are going on. We've evaluated people with different ways of learning, understanding, or different views of the world, and also people with distracting anxiety, that their performance might confirm a stereotype about their group. In order to anticipate and build in modifications or accommodations, we need to strive for equivalence across people and settings, and we need to think about this early on. And that means community partnerships. I think this is a very, very important point here. We need to avoid convenience in sampling strategy. I think some of the marketers and sampling companies really overestimate their ability to recruit certain groups. If we do rely on convenient sampling, we're going to reach the end of our project, and the recruitment of, for example, Tagalog speakers or some other minoritized population is behind expectations. And then we have to rush and use desperate measures to get our Tagalog speakers in the study. This creates ascertainment bias. So, in other words, the sample is not representative of the population. Maybe we tapped into the Tagalog professors in the local university, or Tagalog speakers from just one neighborhood in Chicago. In order to have the power and sample size to establish reliability and construct validity across groups, and to consider intersectionality, which I've just told you is very important, we need large standardization samples that oversample minoritized groups. Consider a participation to prevalence ratio. If a group is disproportionately burdened by a disease, they should be overrepresented in the research cohort. And we should consider a calculation of a fairness ratio across demographic groups that, as standard for development of cognitive measures. I also just want to make a quick comment about measures that say that they're culture-free or culture-fair. It's misleading, and I wish we could stop that from happening, but I think it does all of us a disservice to sort of market measures as culture-fair. So right now I'm going to talk quickly about some of the tools that we have after tests have been developed and validation data has already been collected to determine if our measures are fair across groups. Invariance analysis is one of those measures. It's a very powerful tool and involves latent variable analysis. And I saw a beautiful poster by Jody Sutherland Charvis yesterday who was looking at latent variable analysis of the flanker task. Essentially what we have in measurement invariance is observed variables, which are the rectangles down there, and then we have latent variables, which are these hypothetical constructs or factors that are explanatory and presumed to reflect a continuum that is not directly observable. When we talk about theta or that ability level, that's also represented by this latent factor, that oval up above. And measurement equivalence essentially asks whether the factors are represented, whether the same factors occur within a cognitive battery and the factor structure is the same across groups, whether those tests are related to the construct in the same way, that's metrics invariance, or whether there is a factor that other than the latent factor that causes differences in scores. And so in order for a measure to be equivalent, any differences in test scores should be due to differences in that latent ability. A low score for group 1 should be associated with lower latent ability. High score for group 2 should be associated with a higher latent ability. But that's not always true. And this is Justina Avila-Rieger, who did an invariance analysis on our battery in New York City and YCAP. And basically, she found metric invariance for a number of these items within our tests of memory and in language across race and ethnic groups in the YCAP study. Mainly, it was due to these tests that had really horrible distribution. They were really, the originally designed cognitive tests, and they were, distributed in this way so that most people did very well, and then, there was sort of a cliff after which impaired people would fall off. But that was much more common in people with few years of education, people with who spoke language in our measures, and so that was the source of the metric invariance in our battery. Let me jump now to the issue of cognitive assessment among bilingual people. I heard Richard talk about this briefly. The next two slides were provided to me by Miguel Arce. I just want to say that there's a lack of gold standard approach for determining language dominance and also a lack of agreement to determine the best language of assessment for bilingual people. I think a lot of clinicians and researchers in the U.S. feel that they can make the decision on behalf of the participant by speaking with them in English and deciding that their English was strong enough to be able to have a conversation with them. So now I should be able to test them in English. But conversational fluency is not a sufficient indicator of the language proficiency required for higher order cognitive processing assessed in a neuropsych evaluation. So people who speak English as a second language may acquire conversational proficiency much more quickly than a higher order proficiency. So this can lead to under or overestimating one's proficiency. And what is a better way? There are several self-report assessments of linguistic proficiency that can help determine language dominance aside from having a conversation with them. The best ones ask about age of acquisition, past and current bilingual language use, and bilingual language proficiency. Investigators have also developed several performance-based measures, like this one from Tamar Golan. Many of you know the multilingual naming test. Maybe you don't know that it can be administered in both Spanish and English to the same person. And then a bilingual index score can be developed or calculated, and then you can choose from there which language would be best for the participant. Okay, so I do want to raise this related to the settlement agreement that the NFL made to compensate players who had significant cognitive impairment related to cognition or concussions that they were exposed to as players. There was a huge controversy that arose when several black former players sued the NFL and said that black players were unfairly and less likely to receive that compensation. They cited, in part, separate neuropsychological norms for black and white people as one source of the problem. And I want to raise it here more than anything else because this controversy highlighted the need for improved science, training, and clinical practices around norms in neuropsychology. And I'm very happy to report that there's been an APA Presidential Task Force on neuropsychological test norming in diverse populations that was created in response to this need, and Dr. Maria Marquine, who's a professor at Duke, is the chair of that task force. So let's talk about, I want to show you some of the core principles for normative standards for cognitive assessment, and all of this was sort of underlined by Walter Koroshetz yesterday when he did his intro, and he really spoke quite at length about the need for an understanding of who's normal and what kind of performance isn't normal so that we can diagnose impairment early. And so within this APA task force, we realized there's some core principles that have already been out there by one of the major books for all neuropsychologists, Mitrashina et al. Norms book. And on the slide, I list some adapted and extended principles. So for each normative effort, obviously define the community that the norms are meant to serve, because all norms are of limited use. They can only be used within that community where demographic characteristics are similar. We need to, as I said before, use community-engaged methods as central to the science of norms development, define the appropriate applications of normative data, and the goals of assessment should align with the normative sampling strategy. As I said before, it will often require oversampling. We know that small sample sizes undermine this accurate estimation. They must not have illnesses that cause cognitive impairment. More recent normative data is better than old normative data. And then I think very important here, demographic adjustments must be limited to premorbid characteristics. It doesn't mean that demographic adjustments can't change. People can have more education as they go on and on. People get older and older. But demographic adjustments, anything you adjust people's score for, should not have the potential of being changed by cognitive impairment. So, I've seen out there the discussion of current address being used as opposed to race and ethnicity to adjust scores, because that represents sort of an area deprivation index or, sort of a neighborhood socioeconomic status. But people move sometimes as a result of their cognitive impairment. That is not appropriate. And so we need to come up with things that, make sense. I'm going to quickly just mention robust norms. Is it okay if I go a minute over? Molly, thank you. Just that, what they are in, I guess, 1997, Marty Slowinski found that inclusion of people who would later develop dementia in neuropsychological test norms for older people really suppressed the ability of those norms to detect early MCI. And so what we need to do is follow older people over time and then take people out who later develop dementia out of the normative cohort. That requires follow-up. So we can't just have a one-time cognitive assessment and inclusion of people into norms if we want to have robust norms. So what are our ways forward? First, I think we need a blueprint for inclusive cognitive assessment across the life course. We started talking about some of the elements of that blueprint, but I think that given the need for remote measures, the need for generalizability, and the changing demographics, as well as the advent of technology, this blueprint has to take a new form, and it needs to be discussed. I think that we need to acknowledge the tension between universal relevance of measures and also accurate or precision assessment. The more you try to make your measures applicable to everyone in the world, the less precise you're going to be in some cognitive domains. We need to acknowledge that and find ways to harmonize across measures. And we need increased resources for that. I just mentioned follow-up as one of those increased resources for older norms of older adults. We need more training opportunities in some of the principles that I've discussed, and responsive applications for money, for grant money, for funding that require that teams would build in equity expertise and community partners. I mentioned the need for oversampling minoritized populations in assessment research, and then the workforce issue, which is we've got to continue to diversify neuropsychology. I put the logos of a number of organizations, the Hispanic Neuropsychological Society, Society for Black Neuropsychology, and Asian Neuropsychological Association, that are doing really excellent work, creating affinity groups and interest in these topics. And I think we should support them and partner with them. So thank you very much for your time. It's been great.
Well, I did say it to Jennifer on her way out the door, but I'm going to say it in front of the entire audience. That was just a magnificent presentation, and I think very, very important for all of us in the room who are dealing with measurement science and either the, if not the creation and development of them, certainly the application of them. So really a very important presentation. And the last presentation is going to be very important, too. So our final speaker for the conference is Dr. Shari Ling, Deputy Chief Medical Officer for the Centers for Medicare and Medicaid Services, or CMS, and Medical Officer in the Center for Clinical Standards and Quality. Dr. Ling's work within the agency is impactful on the empowerment of patients and doctors to make decisions about health care. This is what they do at CMS. And on the development and advancement of innovative approaches to improve quality, accessibility, and affordability of health care. Importantly, and for this talk, Dr. Ling has had a committed focus on the achievement of meaningful health outcomes for patients and families, accomplished through her agency's work to deliver high-quality, person-centered care across all care settings. Now, in this particular instance, I can't quite date how long we've known each other, Shari, but it's been a number of years, let's just say that. Dr. Ling is also a valued colleague and someone to whom I've turned to for help and advice on matters of common interest over the years. And she, too, was the first person who came to mind to deliver the talk she is about to give, titled Clinically Meaningful Measures. Dr. Ling.
So I know I am standing between you and your departure or closure of this conference, so I really want to thank Molly and the organizers to have this opportunity to address you all. At CMS, we do very much support person-centered care through policymaking, through programs and policies, and after all, really, the people who we serve it's easy to image the brain. It's hard to wrap your arms around the mind. So we think, therefore we are. And so this is a very important topic to us. And I want to thank you for your work that will support the evolution towards clinically meaningful measures and outcomes for a growing population. So I have no financial disclosures, financial conflicts to disclose. And by way of background, CMS is an implementation agency that implements laws that are put before us to say, thou shalt proceed. CMS is also the largest payer for healthcare services and healthcare delivery globally. And we touch upon the lives of approximately 1 in every 3 Americans. So the scope of reach of the agency is quite significant. The challenge that we have had, and that is present and top of mind for us, is that the population is becoming increasingly complex with aging, but this applies across Medicare and Medicaid, 2 of the largest programs that CMS has authority to implement. What I have here for you displayed is just a snapshot of our 2021 fee-for-service data, where individual conditions appear in the y-axis, and as you move from left to right, there's increasing complexity. So as an example, in the red box here, I have Alzheimer's disease and dementia displayed. In the Medicare population, approximately 5% have only that one condition. So in the yellow, you see 1 to 2 other conditions, and as you move all the way to the right, 54% have 5 or more other health conditions, in addition to a diagnosis of dementia. Why this matters? It matters programmatically, but also clinically, because I would argue that any of these other conditions that appear on the y-axis, that the effectiveness of any therapeutic or any management is going to be only as good as, and it can be amplified if the clinicians, the health systems are aware of a individual patient's cognitive capabilities. And it matters in terms of their communication, their conversation, and that therefore cognition can actually influence health outcomes. And to be able to delineate, measure what outcomes really matter to the people who we serve, this is a strong use case for the work that you do and for the tools that are contained in the toolbox. So I mentioned earlier that CMS is an implementation agency, and the authorities are really built upon the Social Security Act. And I will just rephrase it so in the positive way. CMS and Medicare have authority to pay for, cover and pay for treatments and services that are reasonable and necessary, but not those that are not. As a benefit program, people come into Medicare by way of age, 65 plus, by way of disability, end-stage renal disease, but we also have, CMS has the authority to pay healthcare providers, whether they're clinicians in an outpatient office or any facility participating in Medicare that is being paid by Medicare across the healthcare continuum. And all along this entire continuum of care, there are people who rely on those care and services, people whose cognition, their thinking, their engagement in their own health care is so critical in determining their health outcomes. So this is a bit of a dated slide, but I wanted to highlight that CMS programs and policies are very dependent on the science that evolves, the evidence that is generated, and that this is in the space of both therapeutics and diagnostics. And I would argue that cognition fits in both categories. So as in the therapeutic column, which is on the right, for coverage purposes, there must be adequate evidence to say that a treatment or service using a technology and intervention actually, compared to the alternatives, leads to improved clinically meaningful health outcomes. So if cognitive function is an outcome, here's the path and why it matters. Cognitive function may be dependent on other therapeutics and may be the guide by which a therapeutic may be measured. I will also say that in the diagnostic space, incremental information obtained by a new diagnostic compared to alternatives must be expected to change clinicians' recommendations. That is, the information should be used and useful in the course of managing people who receive care. And that management then results in clinically meaningfully improved health outcomes. And importantly, it's only fair to say that if it is a Medicare policy applied to Medicare beneficiaries, then the evidence should reflect the demographics of the Medicare population. Now, we have the authority also in the preventive health benefit. It's called the annual wellness visit, and we have received requests to annual wellness visit by statute requires a assessment of cognition, does not necessarily require the use of a tool. That tool could be a clinician's assessment of this patient seems to be their usual self. It can actually utilize tools such as those included in the NIH Toolbox. But again, the tool has to be fit for purpose. So is this really a screening? And remember that the preventive benefit follows the U.S. Preventive Services Task Force to say whether or not there's evidence that's sufficient, A or B grade evidence, to require said screening in the annual wellness visit. When applied, though, in the context of people who are having cognitive complaints or what we may call dementia warning signs, is that really screening? It's actually assessment, but can be also covered under the annual wellness visit. So, fast forward years, we're still relying on the evidence that comes to CMS to say that the evidence is now, the totality of evidence is sufficient to require more than what is already covered in the annual wellness visit. We have additional billing codes now to focus on assessment that includes a tool of some type. We did not say which tool, and we'll get into that a little bit later. But CMS also proposed and finalized a national coverage decision for the treatment of Alzheimer's disease with monoclonal antibodies. And importantly, the coverage decisions will follow the FDA, and initially the FDA approval, if it is based on surrogate markers such as amyloid density, then more rigor will be required in terms of participating in coverage with evidence development or as that evidence accrues. But if the FDA approval is determined to be based on outcomes, such as outcomes that measure function, then a registry may suffice, real-world evidence may suffice. Importantly, though, regardless of which path is taken, the questions must be answered that do amyloid antibody treatments meaningfully improve health outcomes, slow the decline of cognition and function? Do benefits and harms, such as brain hemorrhage and edema, outweigh, what is that risk-benefit ratio? And also, are there specific populations that are more inclined to endure risk as opposed to benefit? And how do these change over time, both benefits and harms? Jennifer just gave a terrific dialogue and conversation and presentation on why it's so important to be inclusive. And the coverage determination reflective of the Medicare beneficiary population who will be served must include characteristics of people who look like the Medicare population, including diversity. And that was a bridge too far for the existing evidence available. And there are tools that are used to enroll patients into these clinical trials, one of which CMS is supporting. There are 2 tools named in the registry that permits coverage for monoclonals, but we are very clear to say these are not the only tools. There's opportunity to use others. And a statement that was made earlier about clinician burden, health system burden, timeliness, it really matters because all of this is expected to happen during the course of initial visits, annual wellness visit, welcome to Medicare exam, E&M visits, that's evaluation and monitoring visits for other conditions. It's got to be quick, it's got to be effective, it's got to be useful, and it's got to be usable by the people who, the clinics, the providers who administer these. So the CED funded program, which is Coverage with Evidence Development, also approved additional monoclonal treatments. This is a coverage decision that is open currently and actually has approved 4 studies, 2 of which are registries, one run by CMS, and one is a Georgia Memory Network registry, but also a trial, comparative study run by Beth Israel Deaconess Medical Center. I will say that the tools that were required for entry, they are a start. They do not capture the totality of function for people who actually receive these therapeutics. And I will also say that there's tremendous need and opportunity to go beyond just coverage and this benefit category, but also the future of quality measurement. So in 2017, CMS introduced the notion of meaningful quality measures, and they included domains of person-centered care, safety, chronic conditions, seamless care coordination, equity, affordability, wellness prevention, and also behavioral health. Please know that when we say behavioral health in the CMS behavioral health strategy, we're also including people with and at risk of cognitive impairment, and we have been broad in our definition and inclusion within that construct because clinically and programmatically, mental health conditions, cognitive impairment and dementia, physical health conditions in Medicare population, the Medicare population, as shown in the display of the data snapshot, the population has it all. Very complex. So fortunately, we received a different mandate back in 2014, and earlier the initial panel discussion was teed up with a notion of data standardization, right? And CMS was charged with implementing the Impact Act of 2014. This act requires the submission of standardized patient assessment data elements by post-acute care providers. The list is as you see it here. But what this did was standardize the assessments across the MDS, the OASIS, IRFPI. These are all legacy data collection instruments that are required for data collection and submission to CMS. This information is used for quality measurement purposes to see which facility type is actually performing at a higher, which facility is performing at a higher quality level than the other facilities, but also to be able to compare facility types and track it to what does an individual patient need at the point of discharge from the hospital, from the post-acute care setting, from any of these settings. So the opportunity is there. Data elements must be standardized and interoperable, and originally implemented already in the post-acute care setting, but already tested in an acute care setting and also in the ambulatory care setting. Ultimately, this is intended to not only provide a framework or foundation for measurement, but the point of measurement is to improve. So it is the vehicle for improving care coordination that improves health outcomes, meaningful outcomes for Medicare beneficiaries. And this just summarizes the value, the Lego construct of how can interoperable measures actually do exactly that, but convey the same information that is necessary for purposes not only for inquiry and for scientific investigation, but to converge and permit that convergence to translate with as much fidelity as possible into clinical care and the application for healthcare services. This also can inform future payment models about that facilitate care coordination. So the data elements that have already been standardized actually reside in the CMS data element library. And as I mentioned, it's fit for multiple purposes. It's for the purpose of exchanging information for clinical purposes, but also for quality measurement purposes. Now, what I am showing here is the suite of measures in the quality payment program, which is a statutorily required payment program that assesses quality of clinicians who participate in Medicare. These are the dementia relevant measures. These are specific to people who are already diagnosed with dementia. And as you can see, these all focus on repeating the functional assessment, doing safety assessment, checking in on how caregivers are doing. In addition, though, CMS has enabled through a CPT code payment for cognitive assessment and also assessment of how the caregiver is doing, because we're trying to drive towards value. Value for whom, you may ask. The operational definition, no doubt, cost and quality, converging to inform value, but value for the people who we serve. We have a mission that all people can achieve optimal health and well-being, and that we are a trusted partner in driving towards healthcare that delivers equitable, high-quality care that improves health outcomes. I will also pause to say that if you notice their suite of measures, there is not a single measure that addresses and encourages and incents detection of cognitive impairment. We proposed, we tried, we had technical expert panels who all agreed that there was insufficient evidence to say that detection actually translated to improved outcomes. So I think there's opportunity for future evidence development, but I think it would be wise to look for what is common across measures to be able to standardize across measures. And you can see that in the quality goals that are displayed here, we have a tremendous need and opportunity to be able to utilize tools that can describe and assess patients in the cognitive domain. Cognition, function, meaningful outcomes that are driven by this work. So further information of the National Quality Strategy that also has placeholder language to include assessment as described. And I just want to finish where I started, which is thank you for the work and inviting me here to entice you to think about the use case for the work that you are doing, and that our health system, the people who we serve, rely upon the work that you do. So with that, thank you so much.
Thank you so much, Shari. That was really terrific, and something that we're all going to have to continue to strive for in terms of this space of clinically meaningful measures. So, in closing the conference, I want to take a few moments to recognize the many people who have contributed tirelessly to this effort. First, I want to thank the NIH Blueprint for Neuroscience Research for the support of this conference, without which we would not have been able to bring the information on these measurement systems to the stakeholders here and who have been listening for the past couple of days. I want to thank, again, the keynote and plenary speakers, all of the speakers in the concurrent sessions yesterday afternoon, all of those who presented posters. You brought your expertise and research to us, and we're grateful for the knowledge that was exchanged. So one more round of applause for all of our presenters. It takes many people to execute a conference of this size and complexity, and I really want to take the time to recognize all of the individuals who have contributed to this effort. So, not surprisingly, we had an organizing committee for the conference. These included Aaron Catt, Cindy Nowinski, Miriam Novak, Julie Hook, Richard Gershon, Jerry Slotkin, Jonathan King, Rebecca Homer, Rod Korevu, Justin Reber, Caroline Sferaza, and Matt Sutterer. And more recently, Vitaly Ustinovich joined us, particularly for the organization of the live demonstrations held this morning. My deepest thanks to all of you who've worked for many months to helping us get to this day. So thank you. Our event coordinator for the meeting, Slavica Aikot, assisted by Casey Deans and Kim Schanzer, have done an outstanding job in producing many of the meeting materials and overall coordinating the logistics for the meeting. Our thanks to the team. And additionally, NIH Events Management has been really instrumental in coordinating all of the audiovisual needs and the structural needs, the rooms, the placement of the equipment and everything else during the past couple of days. We've been working with them prior to the meeting, and they've really been extremely helpful and accommodating and supportive. And that includes, particularly for the NIH Events Management folks that did the audiovisual, Diego Constanata, Nate Valagu, and Landy Thompson. In addition to that, Ms. Kathy Bass and Marie Cole were very helpful in all of the coordination. So thanks again to all of you. We really appreciate it. And then finally, a very special thanks to NIH staff who've done everything, literally, and without whom we would have not been able to have the wonderful opportunity for scientific exchange over the past 2 days. And they are Maggie Costanza, and particularly Dr. Justin Reber, Dr. Matt Sutterer, and Caroline Serraza. So please give them a very big hand. This brings our conference to a close, and I want to bring to your attention the screen that has been rolling behind me for the past couple of minutes. It includes the names of all of the experts and contributors to the development of the 4 measurement systems presented over the past 2 days. And if you wouldn't mind continually rolling those screens, I would appreciate it. Thank you. Over 430 individuals have contributed to the substantial and meaningful way in which we have put together these instruments and gotten them out to the public, and we're indebted to their tireless work. So I just wanted to bring to your attention these are the names of all of the individuals who have contributed, several hundred individuals over a period of years, and we're really very grateful for all of their efforts. So thank you. Safe travels home. We appreciate you being here.